So who am I? I am Dr. Melanie Thomas. I am a clinical director for Lymphoedema Wales Clinical Network. We've got 130 members in our team. So that's lymphedema nurses, physios, OTs. We've got paramedics. We've got program managers, data analysts, lots and lots of research. We've got 2 dedicated researchers. So in Wales, we have this wonderful lymphedema network where we see all patients. My speciality is lymphedema, obviously, but it's more breast cancer, although people would say that I am a bit of a specialist in genital edema, but that's a different story, and maybe I'll tell you about that if we ever meet in person over gin. Karen, do you want to introduce yourself?
Yeah, of course. Good evening, everyone. I'm Karen Morgan. As Mel said, I'm her deputy. I'm education and clinical lead for Lymphoedema Wales Network. We're very lucky in Wales to have a great lymphedema service, which is built. It hasn't just happened overnight. Mel and I, well, Mel's been in it since 2001 and I've been in it since 2006, and it has gone from strength to strength, really, which is very reassuring for residents in Wales. But we understand the challenges throughout the UK and the rest of the world. But we do wear our hearts on our sleeve, and we are honest. We're very passionate as well, so we get a little bit excitable. So bear with us, and we'll try and give you a presentation, but then answer your questions. And if we can't answer your questions, we'll do our best to try and find an answer for you. We're a little bit determined and a bit like a dog with a bone. So if we don't know, we'll try and point you in the direction of somebody, or at least try and find some more information out for you. So lovely to see you all.
Thank you, Car. Okay, so let's share this presentation. Now, this is when hopefully it all works to plan. Let's have a look up here. Come on, resume slideshow. Here we go. Can you all see that? Can you give me some nods? Yes, yeah. Fantastic. So this is us. So what we're going to do tonight is talk about lymphedema. What on earth is this oedema? We did video films. What did the little girl call it?
Lymphedema.
Lymphedema.
I got lymphedema. Yeah, bless her.
She was only about 5, 6, and that's what she called it.
Yeah.
So we're going to talk about myths, and let me tell you now, there are hundreds of bloody myths about lymphedema. Okay, so hopefully we can rule out what is a myth, what isn't a myth, where they've got evidence, where they haven't got evidence, and it's all about trying to get some control. My big thing about lymphedema is do not let it control you. Yeah, you've got lymphedema, or yeah, you're at risk of lymphedema, but you control it. It does not stop you doing anything, okay? Because there is always a way that we can work around it, because nobody should stop their life because of this condition. So what is it? Well, it's excess fluid. Lots of people get confused. They think it's something really special, but at the end of the day, it's just a bit of swelling. However, don't call it just a bit of swelling to Karen, because she has a turn, because really that little bit of swelling does matter, and we can make a big difference about it. It can affect the young. The youngest patient we were ever referred was 4 days old. Our oldest was, I think, 102. So it can be the young and the old. It can be primary, and what that means is you can be born with a condition that causes lymphedema. It can be hereditary, and there's some genetics that are involved that, you know, you're born with not enough lymph nodes. You may be born with too many lymph nodes, but they work part-time. They don't function as they should. And then there's secondary, and that's where cancer-related lymphedema comes in. Now, when we started the service in Wales, we were 100% cancer-related lymphedema. Now, only 20% of our workload is cancer-related. And that's because there are so many non-cancerous reasons why people get lymphedema. And we'll come into that in a minute. But why do you get lymphedema? It's because your lymphatic system doesn't work anymore. Now, it may be because it's failed in that you haven't got enough lymph nodes. It may be that it's failed because there's too much fluid coming out and it can't mop that fluid up, or the lymph nodes have been taken away, i.e. surgically, removed, maybe you've had radiotherapy, and they're damaged. So when we talk about lymphedema, there is no universal definition. It is very different across the world. But what it is swelling that has not gone away for 3 months. So if you've got swelling and it's been there longer than 3 months, that is lymphedema. And it's just chronic edema that basically your lymphatic system has decided to work part-time. So causes. Car, do you want to come in as well?
Yeah, of course, I will.
I can say the first one, you can see 75, 65, 100, it's age. So the older you get, the more likely it is you may get lymphedema. And that's because the older we get, we don't move as much as we should. We may put on a few pounds. It may be our veins aren't working as well as they were. We become a little bit sedentary. And that's why exercise is so important and so vital.
Yeah.
Kat, you pick one.
Okay, so the biggest cause worldwide is the filariasis. So that's carried by the mosquito, and that can absolutely wipe out the lymphatic systems. The treatment and management is the same for those people that develop it, but it's usually in the countries that can't afford that treatment or haven't got treatment to manage it. So, and then it just becomes uncontrollable. So you'll see those elephantatic limbs in those areas, really, and it can be destructive. Then the other things are cellulitis. So cellulitis is a complication of lymphedema, but it is also a precursor. So what that means is if somebody has repeated episodes of cellulitis, which is a skin infection, which we'll talk about a little bit more in a while, then actually that makes you at high risk of developing lymphedema secondary to those infections. So we'll talk a little bit, maybe if we get a chance, about some proactive stuff that we're trying to do in Wales to deal with that little bit of swelling before it becomes a real problem for patients to live with, really.
Yeah. Then when you look at your cancers, now it could be that the tumour has invaded some of those lymph nodes. If the tumour doesn't get it, radiotherapy might get those lymph nodes, and surgery, because they're removed. So those are the 3 things there. Then one of the biggest problems with lymphedema, excuse the pun, is obesity. We are a growing nation, and as much as we all try and lose weight, and we will bring up, weight, it is a problem. And we know that the risk of lymphedema developing is 71 times more prevalent if you've got a BMI over 25. I don't know many people who've got a BMI 25 or under, sadly, in our clinics. Everybody's coming in and they are 30, 35. The highest BMI we've ever recorded was something like 89, 90. And there's some other ones that, that are even higher. So we're talking about patients who are 60 stone plus.
If you think, oh, sorry, Mel, go on. So if you think then of wounds and any damage to the skin, your skin is your barrier. You've got superficial lymphatics running through the skin, and that's part of your lymphatic system. And if those are damaged, that can make you at risk of edema as well, lymphedema. Then you've also got surgery. So thinking again about your superficial lymphatics, thinking of the scars, thinking of the surgery, even knee replacements, hip replacements, those kind of things will damage the flow or affect the flow of the lymphatic fluid. So those, when you're getting a bit older, you've got the vein problems maybe, or just the wear and tear on your legs. Then you've had surgery, plus you've gained a bit of weight, plus you've had an infection. So actually it can be an accumulation of those things that then create the edema, which is a problem for people.
So those are some of the known causes, okay? So you can see them all there. So now you've heard us mention chronic edema, lymphedema, and you might, we intermingle these terms all the time because they mean the same thing. I had an email off this consultant, very conceited consultant, I will add, and we don't meet many of those anymore, but it was quite, he's a heart failure consultant, and basically was said, we don't know why you're worried about heart failure patients having edema, you should be more concerned about their heart failing. And we went straight back and said, I'm not being funny, but edema causes a lot of problems for our patients. They can't get their shoes on, they have a wound, they get leaking lymphorrhea. So really impactful. Anyway, so he emailed me today and I was very kind to tell him that, you were thinking about true lymphedema, which is a primary lymphedema, what we are talking about is chronic swelling. And now we've got him on the bus. And you might hear us say that. We always say, try and get these people on the bus so they get it. So 3 different types. Lymphedema, your drainage system is not working. So this is where cancer comes in and your drainage system has been altered because you've had lymph nodes removed or you've had radiotherapy. It's very high in concentration, this fluid that is left. That makes your skin dry out, okay? So it's a normal lymph load going round, but the actual transport, the lymph nodes, they have been damaged. That's why you get lymphedema. Now, there are other types, such as lymphovenous edema. The lymphatic system isn't damaged at all. However, there is so much fluid coming through because they've got this increased filtration rate, so much fluid, it just can't work anymore and it's overloaded. And then lastly, it may be that because you're not moving, you sit in a chair all the time, your veins aren't able to pump that fluid back up because you've got dependency, and then suddenly same thing, you've got so much fluid there that you just can't get rid of. And you might think, well, what's the difference between dependency and what's the difference between overload? There isn't any. It's the same thing. But, you know, it's not just your venous system. It can be that all systems fail because you don't move. And that's why exercise is so important. Now, when we talk about incidence, and you might have heard this from your consultants where they say, oh, don't worry about lymphedema, you know, it's a 1 in 5 chance of you having it for breast cancer. It could be, you know, a 1 in 10 if it's prostate, or even less, you know, if we're talking about gynae cancers or urology cancers or melanomas or head and necks. But actually, the problem is how we identify what lymphedema is. Now, when you look at the measurement of lymphedema, again, there's no universal way how we measure lymphedema. And that is a massive problem. Now, if I was really looking for lymphedema in the public, I could make my research find out that actually lots of the public have it. And what I mean by that is, say for one research study, they look at 10 different points on a limb and they compare it with the other limb. So suddenly they're looking at 10 points. That's much more how can I say, there's much more probability that you will find a difference if you're looking at 10 points if you're only looking at 1 point. I hope that makes sense. Some people only look at lymphedema if they measure one limb. They don't go for the normal side limb. That's again difficult if you've got both limbs affected. Weight gain comes into it because obviously if we put on weight, our limbs get bigger. And then if you've got breast edema or genital edema, it's really quite hard to measure. So when we talk about diagnosing lymphedema, is it a 1 centimetre difference on 1 point, 2 points, 10 points? Is it a 2 centimetre difference? Is it a 5 centimetre difference? And all of the research papers don't measure the same thing. So when you see papers or when you hear people say, oh, you've got a 50% chance, what they are looking at maybe is more measurements at a lower centimetre difference. So if you're looking at all of those papers combined for breast cancer, it's around 20%. But as Karen said, if you're overweight, if you've had a clearance of all your lymph nodes, if you get a cellulitis and a post-op infection, your risk would be higher. But when they amalgamate everything, it's a 1 in 5. If you had sentinel lymph node biopsy, your risk is a lot lower. And that's where they talk about the risks, but there is no universal definition, there's no universal measurement. So basically what I'm telling you is, don't worry, leave that to us. However, if they really want to find it, they'll find it, and you may not get it. So much so that one study measured something like 200 arms, and 9% of those 200 arms had lymphedema, but not one of them did, because none of them had had breast cancer, And it was just that your right arm was slightly bigger than your left because you're right-handed. And remember, that is another problem with handedness. Now, are there other ways that we can diagnose? And yes, there are. So we use a technique in Wales for some patients where we actually inject and we look at the superficial lymphatic system. So we can see where your lymph node, your superficial lymph channels are. If you need the deeper lymphatics looked at, then you have a lymphoscintigraphy. But it doesn't alter any of your treatment. And sometimes it's quite invasive, so we don't always do it. Now, the reason why we may look at your superficial lymphatics is if we're looking for LVA. LVA, lymphatic venous anastomosis, is a surgical technique. We offer it to our patients in Wales, but only 40 of them a year. And that's free of charge. They have it on the NHS for a surgical solution to potentially cure their lymphedema. And we'll talk to you a bit about that at the end. Other things, patient self-questionnaires, pain or heaviness in limbs. So there's lots of differences going on. Now, when you look at the research, it's about 1.3 per 1,000 people have got lymphedema in the UK. In Wales, we started with 2 per 1,000. We're now actually up to nearly 7 per 1,000. And that's because we're a well-known service, lots of people referring to us. So we're more on top of getting people in, and awareness is a bit more. In England, Scotland and Ireland, it's less so. Although Ireland, they've just produced new guidelines. And I think Ireland are, they're not far behind Wales. We will always say Wales is the best because we're not very good at football and we're not very good at rugby at the moment. Although saying that, our coach is back, so you never know. Watch out next year. But the other thing, over 85s, it goes up to 29 per 1,000 people who have it. Now, lots of pictures. I hope some people that won't be offended by pictures, but, I always think a picture speaks 1,000 words. And for me, these are lymphedema patients. And there is a multitude of people where you can get lymphedema, young, old, all over the body. How people describe it: anxious, hospitals, affects my holidays, shoes, sex, intimacy, angry, lonely, personal, lots of things that people tell us, and we'll tell you a little bit more about that as we go on. So how do we assess lymphedema? So the first thing we want to know is, where is it? When did it start? How did it start? Did something happen? And how does it behave? Does it go up and down? Well, if it goes down, what are you doing that makes it go down? If it goes up, why does it go up? I went for a run last night. I personally didn't, but I went for a run last night and my hand was really swollen after it. That's okay. Running is really important. Tell you what we'll do, we'll get a glove on you. So when you go for a run, you wear your glove. That'll stop it coming into your hand. The other thing is, when you're running, you tend to run with your arms slightly bent because we're doing this. The other thing I tell people is, make sure you straighten your arms, give it a little bit of a shake, and the same with your hands. Make sure they're loose. So while you're running, don't always hold a position. Have you got pain? Have you got heaviness? And the way you describe your pain. So is it really lymphedema pain? Or is it that there's a musculoskeletal problem? Is it a neuropathy? Is there a nerve pain going on? And again, when you've had radiotherapy, your nerves are affected. So it may well be that we need to do something slightly different. Now, again, what we've done in Wales, we've introduced Prom. Prom is a patient-reported outcome measure, and it basically allows our patients to tell us exactly how lymphedema affects them. And if anybody wants a copy that you can take to your own practitioners, your GP, just message us and we will get this to you. But it's a 0 to 10. 0, there's no problem. 10, it's the maximum problem. So does your lymphedema cause you pain? Does it cause heaviness? How does it affect your home life, your personal care, your work, your finances, your body image? So when you look in the mirror, is the first thing you look at is, what does my leg look like? Is my leg look swollen in these trousers? Does my arm look big in this jacket? Intimacy, desirability, really important. And yet we know lymphedema does affect it, because sometimes we ask you to do things at night. And really, then what we say is, why are you doing it at night? Don't bother at night when you want to go to bed. And if it's intimacy, desirability, sometimes, you know, putting the cream on, doing the massage, it can affect different things and how you feel. Don't do it at night. Garments, they're not very sexy, let me tell you, but we will try and work with you on these things. So as you can tell, Karen and I are very open with our patients, and we do talk about sex and intimacy, desirability, because we've got to. We treat people who have genital edema, and one of the worst things that people say about genital edema is they want a confident therapist. They don't want somebody who says to them, have you got any swelling down below? Or do you have any swelling, you know, in your genitals? They want people who know what they're talking about, and we've done quite a bit of research on this. So does lymphedema affect walking, anxiety, hobbies, holidays, shopping for clothes and shoes? Our number one problem in Wales from our patients out of 13,000 proms is shopping for clothes and shoes. We would never have known that had we not done Lymph Prom. Okay, Car, over to you.
Okay, the other thing to say about that is the Lymph Prom, Mel and I very much treat people as you would want to be treated, and be open, honest and transparent, and we hope that we influence that through the team that work with us. As Mel said, there's 130 of us now. And I think what the Lymph Prom has also allowed us to do, people look in and think, oh my gosh, lymphedema services in Wales, they've got it to a T. But actually, we've had a lot of failures as well as a lot of positives. But we have patients on our strategic board, we have patients on all our groups, because they are the people with lymphedema, or the stakeholders, I should say. We're all potential patients. What's really important for me is that their voice is heard, because we work with it, we don't have it. We need to understand the impact so that we can develop services and shape services for the stakeholders' need. And what the Lymph Prom has allowed us to do is actually have permanent funding for a psychologist, which is pretty impressive when other areas can't get that. So, you know, we're asked to collect data from patients, which we do, but then we expect Welsh Government to act on that data, because otherwise we're not collecting data for data's sake. So what we collect, we act on. So, okay, so when we do an examination, Mel said about the different ways why we try to diagnose lymphedema or chronic edema, or any edema in that area that Mel talked about, any area. So we're not just measuring, we're looking at the skin, we're listening to what the person tells us about how the limb feels. We're looking at whether the shape of the limb, the tissue changes, whether it's firm, whether we can pick the skin up. So if you can pick the skin up, that's what we call a negative stem, as if you can't, it's positive. And that would indicate that there's edema of some type in that area. And as Mel said, regardless of the reason why it's there, it still needs support to manage it, to enable people to have an improved quality of life and reduce the risk of all the complications that can occur because of that edema. So we're looking at the circulation, we're looking at the venous circulation, the arterial circulation, the blood flow to there. And then we're looking at whether it's pitting or non-pitting. So if it's pitting, that means we would push our thumb down or our finger on any area, and we would hold it there you can hold it there for up to about a minute, but usually you can see it within 20 seconds, whether it's leaving an indentation, as you can see at the top picture there. What that tells us is that there's fluid there. If it doesn't pit, then that would make us think that it's more of when the fluid's been there for a long period of time, the fluid that's left in the tissue reacts with the collagen, and what happens then, it becomes more custard-like. So that fluid then changes and becomes very thick. That's important to remember, because to break that fluid up, the leg or the arm will get bigger before it gets smaller. So you've got to break up that fluid, allow it to be thin enough to move, and then the limb or the area will get smaller. And I think not a lot of people explain that. So sometimes people will be bandaged or have compression, their limb will go up, and that can be quite scary for somebody because they think the treatment is making it worse. But actually that understanding that we've got to break that tissue or that fluid up first. Then we've got to measure and do weight and height, as Mel said, because it could be that you've gained weight rather. So you're looking at whether the treatment is effective. You're diagnosing, first of all, if it is edema, how you can manage it, and then you're monitoring that. So you need, Mel talked about patient-reported outcomes, but you need clinical reported outcomes as well. So the clinical effectiveness of what you're doing, so what you start with, and then how you treat it, and how you monitor that then to see if it's been effective or not. And that will include what Mel said, the volume. So other factors, you know, are the muscles weak? Does that have an impact? What's the activity level of the person in front of you? It's very individual. Are they athletic? Are they inactive? Because then you can do a personal plan for them to increase that, or the frequency of it. So actually it helps the compression to work, because you will be aware that, or you might not be aware, sorry, actually, that the lymphatic system doesn't have a pump. It's reliant on the muscles. We will go into this a little bit. So how do you make that muscle work harder? So you put an external force, which is compression, around it, which makes that muscle internally work harder than it was working, and therefore moves the fluid away. So how much movement have they got? Has the person got? Are they struggling to do daily tasks? What's important to them? What's their mobility like? Do they need walking aids? Do they need help? And where do they sleep? And the reason we ask where they sleep is because if your legs are down, this is primarily legs, but it can also be an arm. If your arm is in a position that it's not being raised up, sort of so the fluid can drain, then you're going to have what we call dependency edema. So you might have a bit of lymphovenous edema, a bit of lymphedema because you've had cancer surgery or lymph glands removed, and then you've got a bit of dependency edema because you're not as mobile or you're sleeping in the chair. So that's when we were saying that it can be a multitude of things. Some people can have cancer treatment, be very well and not have any lymphedema at all till 10, 15 years down the line. We would want to know why that's happened, but it could just be that maybe you've had an infection. So that first assessment, or your activity levels have reduced or you've gained weight, but that first assessment is key to try and understand why it's developed. Do you want me to go? You go?
No,
yeah.
That's okay. So when Karen says break, we're not actually going to break your leg, okay? We're not going to break your arm. But what we do is we break down the tissues that are rock hard and solid. So this custard-like, and how we do that is through massage. So it's slightly deeper massage to break the fibrosis, and then we use different products like foams in the bandaging or foams in your garments.
Apologies if I terrified everybody about breaking
yeah, we're breaking limbs. No, we don't break limbs. Okay, so starting and then what can we do? You know, everybody talks about self-management. What is self-management? It's about being informed what we should do to look after ourselves. And lots of this is common sense. So skincare. And it really winds me up when people say, you know, I say, right, tell me what you do. Oh, I do skincare. All right. What is skincare then? Well, you know, skincare. I said, no, I don't know. You tell me. Well, what does skincare mean to you? And I do this to therapists as well, if I'm teaching. And then they say, oh, you know, to keep my skin supple. I'm thinking, really? So skincare, the reason why we want you to look after your skin is to prevent a cellulitis. That is all we want you to do. So by putting cream on, it creates that barrier that you're not going to get dryness of your skin, the bacteria can't enter, and you don't get a cellulitis. Because a cellulitis makes your lymphedema worse. That's it in a nutshell. So that is why we want you to look after your skin. What do you do about cuts and burns? Again, lots of information you'll see, avoid cuts and burns. And it makes me laugh because I think, well, we're not going to do it on purpose. We're not going to cut ourselves on purpose. We're not going to burn ourselves on purpose. So when it says avoid, it doesn't really make any sense. So what we should be saying is, if you do cut yourself or burn yourself accidentally, then watch that area doesn't become red and hot, that you may have a cellulitis. That's what it means. So I'm going on holiday, like we were last week, but I'm going somewhere hot. What do I do about my garments? Lots of patients ask me these questions. And I just say, right, where are you going? Oh, I'm going to the Caribbean. How lucky for you. You're going on the plane, make sure you wear your garments on the plane. Walk around. Yes, you can have a little drink or two if you want, alcoholic, but make sure you do drink your water too, because we need to be hydrated. So yes, for garments. But when you get out there, and it's boiling hot, yes, you can take them off. Yes, you can take them off to go in the pool, because the pool, you've got hydrostatic pressures that will mimic your garment. When you come out of the pool, it's boiling hot, dry off a bit, then might say, okay, tell you what, put your garment on in the afternoon, or put your garments on to go to bed in the night. So when you've got air conditioning, tip it upside down, wear them to bed. It's not a problem. You are in charge. However, if your lymphedema is getting worse, then you think, well, do you know what? I tried that, Mel. My swelling was a bit worse. I'm going to wear my garment today. And then you'd wear your garment in the pool. Yes, you can do that. What I will tell you to do, though, is make sure you wear suntan lotion, because you do not want to burn. Why do you not want to burn? Well, being sunburned is painful, but it might cause a cellulitis. Back to the same old reason. Lots of people say to me, what about creams? What have I got to use? Have I got to use these medicated creams? Well, if you've got really significant lymphedema, then and you get cellulitis, then we may suggest, yes, you do need a medicated cream. But the majority of patients can just have Nivea, cocoa butter. They can have, if they're really posh, they can have LMS or Molten Brown, and it's a nice smell. So whatever you've got, just put it on. Now, I know the evidence, and I know I should moisturize, but I tend not to, because I haven't got time. But I'll go in the shower and I will use a moisturizing shower gel. And if my legs feel dry or my arms feel dry, yes, I will put it on. Yes, I'll put all the Trini on my face, because I'm into Trini now. It's very nice, if anybody's wondering. I'd put Trini on my face, but I very rarely do put it on my arms, but that's not good. You should put it on a little bit more. But if my arms were dry, then yes, I would put it on. Bites. Yes, it can cause cellulitis. So if you're prone to mosquito bites, then definitely use something that will try and prevent it. So that's your skincare in a nutshell. And we'll talk a bit more about this when we talk about myths. Karen, cellulitis.
Okay.
This is Karen's baby.
Yeah, so I'm a nurse by background. I'm a non-medical prescriber. So I prescribe antibiotics for people if they either present with cellulitis or if they need to go on long term. So cellulitis is a skin infection. If anybody's ever had it, it can be very disabling and painful. Oh gosh, you've moved forward, have you? Or did I do that?
I was going to say, there's your symptoms.
Oh, there we are. I thought then I didn't have, yeah, I don't like not having control, but there we are. That's okay. So you become unwell, you become feverish, or you can do flu symptoms. You won't get a bilateral cellulitis. Well, I say you won't, it's very rare. I have seen it once, and that's not to say that it never happens, but it is extremely rare. Excuse me. So it can happen on any part of the body. It usually presents as hot. You can develop a high temperature. It can become swollen or more swollen. If that area is swollen normally, it's painful. The skin can blister. It can develop into a rash or just a red area. And sometimes you just feel generally not right. The treatment for the cellulitis, you know, it's a medical emergency. And why I say that is because cellulitis can develop into sepsis. Sepsis, you know, it can be fatal. So if you know, it's a little bit like if the cellulitis starts, then you need to have a medical review as soon as possible. So you can obviously take analgesia, you can try cold compress. There's a little bit of a myth around you can't put garments on. You can wear a garment. Usually what happens is it's too painful to have a garment on. So if you have an area, a paper cut on your finger, that's extremely painful and you don't want anything over it at that time. So imagine a limb that's cellulitic, hot, painful, you feel really rubbish and it's more swollen. So people tend not to, but there is no reason why you can't. And the advice we give to our patients is if you can tolerate an older garment, or if you're wearing 2 layers, then take it down to 1 layer. If they were in bandaging, reduce the level of the bandaging, because the problem is you will have acute edema and chronic edema, and that will take a lot longer to resolve following the cellulitis. So You just need to be, it's driven by the person, the individual. So we have some guidance around prophylactic antibiotics. There's a big thing around antimicrobial stewardship at the moment, and people being on longer term antibiotics, but there shouldn't be a fear around appropriate prescribing of that. The challenge for me as a prescriber is if people dip in and out of their antibiotics. So if you have a course and you don't complete it, that can make you develop some resistance. So it is much better to finish those antibiotics. And it obviously is appropriate only for bacterial infections, not viral. It doesn't work on a viral infection. And we've just created an antibiotic policy around just in case. So we work very closely with the microbiologists, the antimicrobial pharmacists throughout Wales. And a lot of patients that have ever had cellulitis, you can share with us after you might have had it. It makes you very fearful that you might have another one, and it can be very sudden. And it doesn't happen Monday to Friday, 9 till 5 when the GP surgery is open. It happens in the middle of the night or out of hours. So it gives people control. If they have the antibiotics, they're ready to start. There's a strict criteria regarding this, because of antimicrobial stewardship, but it's important, I think, to allow patients to be in control. The fear factor and the delay in treatment can lead to somebody developing sepsis if we're not careful. There's a lot in the press at the moment about strep A. Strep A can be a cause of cellulitis. So if you are prone to that and you develop that, that needs appropriate treatment. And there's a little bit of thing in the press around the limited amount of antibiotics. There's a lot of scaremongering. I wouldn't concern yourself about that. I think the most important thing is that you seek medical advice as soon as possible. And some patients say to us they get a bit of an aura and they know they're going to be unwell. That's enough for me. If someone tells me that and they've had it before, then I listen to what the person is telling me. It's the same if somebody's asthmatic or any other condition. They can usually tell you that something's going to go wrong. I'll use myself as an example. I am an asthmatic. As soon as I go off coffee, I know I'm heading for a chest infection. So but that isn't scientifically proven, but I know that that's going to happen to me. And I would expect my GP to listen to that, because I'm my personal own expert about me. So I don't know if you want to go back, Mel, to the other slide. I think I might have covered everything there. So basically you can see there is a huge impact on patients, as I said at the beginning, whether you are at risk of developing lymphedema from it, or you have lymphedema and you can develop cellulitis. And as you can see, it increases your risk by 71 times because you've got the lymphedema. What I want to say just here is fungal infections is really important to remember here. So if you have an untreated fungal infection, it can develop into cellulitis. So it's really important that you treat any fungal infections. Remember that the lymphatic system is all over you. So fungal infection in your toe can affect a breast edema. So just remember that it is important to manage the whole of your skin, if that makes sense. And what's a really good thing if you do have repeated fungal infections is a tea tree wash. So there's a little tip for you rather than using a medication. Do you want to do this bit while I have a bit of a cough?
So this is talking about weight management. Now, Karen and I, we briefly looked at this earlier, and all the evidence is there. We all know the evidence. We all know public health. We all know about, the Eat Well guide. We know we should be eating more vegetables, less fats, and proteins are good. However, is it really helpful? I can tell you lots and lots of stories where I see patients and we talk about, okay, you've put on 2 stone. Everybody seems to have put on 2 stone over COVID. I don't know why, coming into clinic. And, and they will say, but I don't eat very much. I don't understand why I've put on weight. So the first thing we look at, medication. Okay, what medication are you on that could be causing weight gain? And we know straight away, yes, lots of hormone-related medication can cause weight gain. We also know that certain things like amlodipines that are given for blood pressure, high blood pressure, they can also cause some edema and can cause weight gain. So we look at all different things first of all. And then we start saying is, okay, tell me, let's talk through the day, and if it's in the afternoon, say, right, what did you have for breakfast? Oh, I had XYZ. Okay. Do you drink tea? Do you drink coffee? Yes, I have a cup of tea. I'll tell you what I do though. I have a biscuit when I have a cup of tea. Oh, right. Okay. What did biscuit you have? Because I'm always interested. And they might say, oh, it's a digestive. Right. Do you have a digestive every time you have a cup of tea? Yeah, I have recently. How many cups of tea do you have? About 5. So then we say, well, that's 5 digestives. Do you know that's nearly, 400 calories? Oh my gosh, I've never thought of it that way. So what we try and do now, we've tipped it on his head. Yes, we all know about healthy eating, but we all know that, to lose weight, eat less, move more. But it's really, really hard to do that. So we try and think about it differently. We talk about being food aware. We talk about thinking about, well, instead of trying to lose weight, can you stay what you are for the next 3 months? Oh yeah, I can try and do that. Do you actually even know what you weigh? Lots of people don't know what they weigh. Again, we get people coming in and they say, oh, I think I'm about 10 stone. And then we weigh them, they're about 13 stone. And it's so easy to creep on. It's so hard to get off, but it's so easy to creep on. But we set these realistic goals, but they've got to be shared decisions. So it's all good and well me coming in and saying, right, you are overweight. We need to get your BMI down. When the next time I see you, I want you to do that. But that's not a shared decision. What we need to do is, look, I can give you the evidence. We can work together. What can you add into this? And some people are not ready for that. And they'll say, look, I cannot think about my weight at the moment. I've got, I'm in the middle of getting the kids to school. My mum's really unwell. The car's on its last legs. I can't think about that. And we'd say, that's fine. That's not a problem. When you're ready, we'll be ready to pick it up. And obviously there are dietitians. There's lots of good advice out there. And we work together. There is a lot of press at the moment for some patients who are using medication to lose weight. And there is some good things out there, but it is something to talk to your GP about. These are things like semaglutide, omeprazole or something like that. They're diabetic drugs, but they do make you feel fuller. Now, we're not advocating it, but we have had a number of patients who've gone on this type of medication privately through medical input, and they have lost weight. So there are things out there that may help us in the future. So activity. Now, Karen said this a little bit at the beginning, when we treat people as individuals. So if you're athletic and you tell me, Mel, I do extreme sports, I've got lymphedema, have I got to stop? No, you have not got to stop. What we need to do is work together that we can maintain your lymphedema size, hopefully reduce it with whatever sports that you've always done. Now, if you're coming in and said, I want to run a marathon, and I'll say, oh, brilliant. Okay. How many 10Ks have you done? How many half marathons have you done? Oh, I haven't done any. Then we would say, okay, let's start with a 5K. Let's do something slightly different first before you want to run the marathon. But lymphedema should not stop you doing anything that you want to do. Horse riding, motorbiking, windsurfing, anything, skiing, snowboarding, you can do it. And that's it. So we advise there is no precautions, you can do it all. So the benefits of movement, you know all this, we all know it. But for a lymphedema side, it does get the fluid moving around. It does prevent stiff joints. It helps, supports weight management. It's really good for our mental health. Karen and I used to go to the gym and we used to have a really good laugh and we were a lot fitter and we're going to start back again. But we are busy people and we wear our Fitbits and we make sure we do our 10,000 steps a day. And that's another thing, is there devices there that we can support our patients, maybe by starting off doing 1,000 steps. Some people only do 100 steps a day. So just starting slow, but it is core to treatment. Now, this is here for a particular reason. When we've done lots of scanning, we encourage our patients to exercise and move to try and get those lymphatics moving. And one of the biggest things we found that moves lymphatics is shaking a limb. And you might think, what on earth is shaking the limb? And it's literally holding your arm up and giving it a really good shake. And you do it for about 20 seconds, and then you can pop it down. And then you might do the other one because you don't want that one to feel, left out. But lymphedema limbs, shake them. And you might think, well, how do I do that with a leg? It's quite easy when you're lying on your back, lift your leg up in the air and you literally shake it. and it stimulates all the lymphatics. If you've got breast edema, you can still do it with breast edema. I can't believe I'm doing this on screen, but it's called the shimmy, okay? And what we do is we shake everything coming forward and we shake everything coming back. And that is a shimmy, and it shakes everything. And if you've got a big tummy, then that will shake that and all. And genital edema, we encourage pelvic floor and a bit of shaking of the pelvic floor. So that's something you've learned. Compression garments, there are hundreds of them, hundreds of thousands of them. They come with zips, they come in different colours, different fabric. If you don't get on with a compression garment, I can guarantee there is another one out there that you will get on with. Never take no for an answer from your lymphedema services. They may have a contract with one particular supplier, but that doesn't mean that you will get on with that supplier. So then you say, I want a different supplier. Patient choice always comes into it. So as I said, there's lots of different colours, lots of different products out there. You know, at the moment, there's about 8 suppliers, and they've each got probably about 20 garments. So suddenly that's 160 garments that you could choose from. Yes, they start you off on the cheaper fabrics, and then they work their way up. Made to measure is not the best product. And why I say that is made to measures are made for your limb, but that doesn't necessarily mean that they will then make your limb into a normal shape. Because if you think about it, made to measure is just going to fit your limb. It's not going to push it in to create a normal shaped limb. We've done lots and lots of studies with made to measures. There is a 20% tolerance on made to measures. And what that means is if you've done a 20 centimetre measurement, 20% means that could be 16 centimetres or it could be 24 centimetres. So if a garment doesn't fit you, it means that there is a tolerance rate and you need a new product. And if any of your lymphedema specialists say, oh no, you can't, say, go talk to Melanie Thomas from Wales. She'll tell you. Okay, so you can send them all my way, I don't care. So what does a garment do? Obviously encourages the fluid back on. How do we decide? And this is important. We want to know what your job is. So if you are a teacher, you may not want your hand being shown. But if you've got hand edema, then yes, you do need to wear a particular type of garment over your hands. But we might say, look, don't wear it in school. As soon as you come out to school, then put it on, because you don't want to answer questions to the children. What are your hobbies? You know, you might have particular hobbies that you really love, clay making, pottery making. Again, we say don't wear it. Nurses, we have a lot of nurses, and you've got to be bare below the elbow. So again, we say don't wear it in work. As soon as you come out or on your break, you put it on. But there are ways, there's lots of products out there now, like huge rubber gloves that you can wear. I've already mentioned intimacy, desirability. Don't wear the garment. Put it on tomorrow. And you might think, God, this is really different to what I've been told. We've been doing it a long time. And let me tell you, limbs don't go up overnight. So if you want a night off, have a night off. So we look at the extent of swelling, the skin changes, your age, can you get garments on, how many layers you can get on, but your choice is vital. Otherwise, you're not going to wear it. So if you love a pink garment, have a pink garment. If you want a red one, we'll find a red one for you. Instead of German ginger or instead of black. You know, those are the normal two, but there are other products out there. How to get your garments on and off. If you struggle, get some rubber gloves. I use a lot of gardening gloves because they are more silicone based and they're actually a little bit firmer. But you need to be taught how to get these garments on and off. But there's lots of products there that can help you get them on and off. They could be rigid frames ones, which is actually called Melanie. But I've got nothing to do with it. It used to be called Simon, so I don't know why they did change it to Melanie. I need to find that out. But you can see slippery fabrics that can slide on. So lots and lots of different things there. I'm going a bit faster because I want to have time so that you can ask us questions. Compression garments, wraps. Again, there's lots of devices now. And you'll see some of these products. There's a new product called, what's it called? Comfy Wave. Is it Comfy Wave?
Are you talking about the made to measure, or are you talking about the one at the bottom?
The one at the bottom from
yeah.
Hardeman.
Oh, they were with us yesterday, weren't they?
See, this is perimenopausal women for you.
It's a nighttime garment. It's a nighttime garment. It'll come to me now by the end of the session, maybe. It's a nighttime garment, but it can be used in the day. So
okay. And
I'll try and remember what it is.
It's a nice garment, but there are other, what I'm trying to say is there's other products for you. If you don't get on with wraps, shared decision making, let's give you the evidence of the products. You make an informed choice. And we've got all that. So, myths and evidence. Now, it's entirely up to you. You can come off mute. These are all myths and evidence. And what we're going to do now is go through what you think is a myth and what you think is evidence. So I'm going to start with the easiest one. Healthy weight, BMI 25, lots of evidence behind it. It is definitely evidence. Use washing up gloves. Wear oven gloves. Do you think there's evidence behind that?
Absolutely. No evidence?
No evidence whatsoever behind that.
But if I wear oven gloves, I'm not going to burn myself as easily.
True. So
okay.
Obviously, the reason why it went in there was to decrease the cellulitis so that you could potentially avoid a burn. And that's what it's there for. But there's no evidence.
Got it.
There's
Okay.
No
I mean, I used those gloves before I ever had lymphedema. So there's
no research behind it, but it's a common sense thing to do. But as I said, lots of people think, oh my gosh, I've got to do this. No, you haven't. No clapping your hands together. Use your unaffected hand on your thigh. What a load of rubbish. These were recommendations that you will find online. There is no evidence for that at all. If you want to go to the theatre, you clap your hands. If you've got upper limb lymphedema. Avoid dog walking in case the dog pulls your arm. No evidence. No body piercing. There's no evidence for that. And if you really want a body piercing, you can have a body piercing. Don't worry about it. Tattoos. Now, this is an interesting one. There is no evidence behind it, although there is some research coming through now about red dye. If you think about nipple tattooing, that's all right, because it doesn't cause lymphedema. But if you were going to have a tattoo on your lymphedematous limb, then I would say, do you know what? Can you have it on the other side? But if you really want it, then we'll work with you. And if you really want to do it, then do it. But there is a little bit of evidence that may suggest it could cause a cellulitis and it could increase your lymphedema. Some people say quick baths, don't have much heat. The opposite to that is they say don't go to extreme cold. There is no evidence for that whatsoever. So if you want a hot bath, have a hot bath. Now, hot tubs. If you've got lymphedema and you want to go in the hot tub, then that's fine. But what I wouldn't recommend is going in the hot tub if you've got any cuts, because that could cause a cellulitis, or if you've recently shaved your legs or your armpits, because again, there may be a slight nick and that could cause a cellulitis. So if you're planning on going in a hot tub, make sure if you're going to shave your legs or your arms, make sure you've done it 2 days before so that actually, you're not going to have an opening. Now, when we're talking about shaving armpits, if you've had radiotherapy, you probably might not have any hair under there. But what I would say to you is, if you want to shave your armpits, you can shave your armpits. The only thing I would recommend is make sure it's a clean razor, that it isn't one that's been in the shower for a year and it's got lots of rust in it. And we all know sometimes we have looked at it and thought, oh, looks a bit dubious, or it'll be all right. I wouldn't recommend that if you've got lymphedema. But if you've got any, when you've had surgery underneath your armpit, you may find that you'll have lots of creases and scars. You may find like a product like it used to be called Immac, I think it's Veet now, or it might have gone back to Immac, I'm not too sure. You may find those creams slightly better. For legs, if you want to shave your legs, you shave your legs. Just be careful and make sure it's a clean razor. Okay, what other ones? Underwire bras, no evidence at all. If you want to wear an underwire bra, you wear an underwire bra. Use a thimble when sewing, only if you want to. It's not a rule, okay? Elevate your arm and leg. It's not a rule. But what I would say is, if you know, and then you think, why did they say sleeping in a chair? You'd be amazed at the amount of people who sleep in chairs. So what I would say is, you know, yes, elevate to go to bed, but you haven't got to walk around and hold your arm up, or you haven't got to watch telly and, you know, put your arm up on the side of the settee. There's no evidence for that. What other ones? Loose, comfortable clothes. No evidence whatsoever. Avoid playing badminton, tennis and golf. No evidence. It was to do with repetitive movements, but that was poo-pooed a long time ago. But the evidence, the information leaflets that are still there, they're out of date. Now then, this is an interesting one. Avoid venipuncture and injections. Now, if you're at risk of lymphedema, there is no ruling to say that you should not have injections in your affected limb because you haven't got lymphedema. If you've got lymphedema, then ideally go in the opposite side. But if it's a medical emergency, do not worry about it. We have injected, oh gosh, I don't know how many limbs, probably about 1,500 limbs with a dye when we're looking at lymphatic venous anastomosis. How many of those 1,500 limbs have increased in size? 0. How many have had a cellulitis post-injection? 0. And that's because we do sterile techniques. The evidence on venipuncture and injections is from 30 years ago when surgery was extremely different. Okay, so lots of newer research is coming out now. Ideally, use the other side, but if it's in a medical emergency, just have it. COVID injections. There is some, how can I say, it's not evidence, but there are some reports that COVID has made limbs worse. However, you were talking about maybe 100 people versus 100 million people who've had a COVID injection. So when you look at probability, the probability is extremely low. But that's not to say that some patients have not reported that COVID has made their limbs slightly worse and they've worn their garments and then it's back under control. No lifting, weights, extreme sports. I've already told you that's a load of rubbish. You can do that. Do not have massage. There is no evidence for that. So if you want an Indian head massage, if you want aromatherapy, if you want reflexology, if you want aromatherapy, full body massage, you have it. Because
even deep sports massage on a limb. Okay.
Even deep sports massage, because what we found is actually when we've done the deep tissue massage, when we're doing the scanning, it actually improves drainage because suddenly the fibrosis is released and suddenly those channels have got room to move. So have it. Lots of this evidence has come from good meaning professionals who all got together and said, yes, this is what we recommend because we don't know any different. But nowadays, there's more and more proper evidence coming out. So there is no evidence for, there's no evidence against. So if you love massages, go and have a massage. And I've spoken at length to some of the gurus in lymphedema, like Professor Peter Mortimer, and you know, he'll say the same thing to you. There's no evidence. What other ones have I got on you there, Kai? I can't see them all now.
I think you've covered most of them. Somebody's asked about a sauna and somebody's asked about acupuncture, but we are just over 7:30, so I don't know. I know.
I'm so sorry. Right, okay. So I think, so there's the green ones. Those are the ones with lots of evidence. Everything else, no evidence. So can we improve limbs? Yes, we can. Yes, we can. So tips and tricks: manage your lymphedema. Do not allow it to manage yourself. Live your life well. And there's lots of video films. If you want to take a photo of this, or we can put it on for you, there's loads of video films that you can watch. And it's Karen and I on there. And we're exactly the same on the film than like we are here. So I'm going to come off this and let's have a look now then.
So it was saunas, Mel, acupuncture, and I missed the last one.
Stop sharing. Okay, saunas. There was one study that was done and it was a questionnaire looking about, does a sauna cause lymphedema? They said it did, but when you look at the quality of the evidence, it wasn't great. And it was a patient self-reporting questionnaire. There's not been like a really randomized controlled trial. So what I would say to you is use your common sense. Go in for a couple of minutes, come out, see how your lymphedema reacts. If there's no reaction, next time go in for 5 minutes, go in for 10 minutes. That's it. Acupuncture, have acupuncture. There's not a problem why you can't have acupuncture as long as it is sterile. Yeah. And all your acupuncturists are. The needle is tiny to have acupuncture. They can go on the opposite quadrant. I've done acupuncture myself. You can go on the opposite quadrant. It can have the same effect. But I've often used acupuncture on lymphodematous limbs.
The other things are shoulder bag, blood pressure.
Load of rubbish. You can put your bag anywhere you like, but use your common sense. I did have a bad shoulder because my bag was so heavy. I then got a rucksack, and funny enough, my shoulder pain went. So use your common sense, but you can put your shoulder bag on your shoulder.
So these myths and truths are Mel's PhD, which she's supposed to be writing up but hasn't, because we're all busy doing other stuff. So I'm sure that she will share the information, and hopefully it'll be published very soon. Blood pressure.
Blood pressure. Now, again, there is no evidence to say this. However, people will report, my lymphedema started after I had blood pressure taken. What you've got to sum up is how many people have blood pressure taken, how many people get lymphedema from it. It's the probability. The probability is extremely low, but you might be one of those people who it does occur. If you can go for the other side, go for the other side. But if it needs to be done, it needs to be done. Repeated blood pressure, probably go for the other side. If it's one-offs, it's not a problem.
And waxing. The waxing is like shaving. It's this, not like shaving, but the same. So if you cause any damage to the skin, it's the risk of the infection. So hair removal is better with a cream, but you can, as long as it's as clean as it can be, then it's about reducing your risks associated with that, really. Waxing,
somebody's asked me about. Well, waxing can be quite abrupt. You know, having it done myself very occasionally, you know, it can cause your skin to bleed. I would probably suggest, you know, if you've got lymphedema and you want waxing on that area, I would probably say don't do it. But if it's in an area that hasn't got lymphedema, carry on. Blood pressure, I've done that. Can you have a copy of the presentation? Of course you can. Can you please put a link for videos in the chat? Yes, we can. How often do you recommend the shaking? As much as you like, but don't let it take over your world. You know, some people I say, listen, when you go for a wee, because that's the only time I have quiet peace in my house with 2 children and a dog, although the dog's trying to get in there as well. So when I sit, and then I might do a little bit of shaking like this. When I go in the shower, have a little bit of a shake, and you will see a difference. What you'll feel is a tingle, and that is the lymphatics suddenly working. Oh, thank you. Sensible advice. We try and be sensible. Thank you. Oh, thank you so much, PJ Morgan. So glad. Wish we had more chance for questions. Can we do it again? Yes, we'll do it again. High voltage electrical stimulation. Yes, you can have it. If you mean TENS machines, yes. If you're talking about things that make the muscles contract, yeah, definitely you can have it. So sad the most areas in England don't have. I totally agree with you. We did try, Karen and I went to Westminster. It's very different in England. You should just move to Wales. That's my answer. But we are trying to improve services in England. But it's hard because Wales is probably the same as one of your primary care areas or one of your CCGs, whatever they're called now. You know, we're only got, what are we, 4 million or we 2.4 million? Again, this Perry
yeah, we're like the size of maybe 1 or 2 CCGs.
Yeah, so that's the problem there.
Yeah.
Thank you, that's nice. Okay, so I'm just seeing if there's any more questions. No, I think we're there. So if you do have any more and you want to talk to us, we're quite happy to stay on a bit longer. More than happy if you want to ask us anything.
I would love to stay on.
Yeah.
This is PJ. You mentioned the surgery.
Yeah.
Well,
So
tell me your thoughts about it.
Okay, so there's a few different surgeries available.
Yeah.
The first one they look at is lymphatic venous anastomosis.
Same as is that the same thing as lymphovenous bypass?
Yes, similar.
Okay.
Similar.
Okay.
Same horse, different jockey, but it is similar. So what that means is your lymphatics are defunct, your veins are functioning, they will move the lymphatics and they will attach them to the vein. Now, we've done 150 patients in Wales have had it, and we followed those patients up for 2 years. The results are good in that pain is better, heaviness is better, quality of life is much, much better. Garment usage has decreased. What hasn't changed much is volume. So the size of the limbs are about static, but you don't have to wear your garments anymore. Now, for me, that's a win.
Yep,
and patients will say, yeah, I'll take that. Thank you very much. If I haven't got to wear these garments and my limb stays the same, that's good. The other thing it's shown is that your cellulitis recurrence rate decreases by something like 95%. So that's LVA, lymphatic venous anastomosis or bypass. The next one they look at is actually a lymph node transfer. So what they do there is they take away functioning lymph nodes and they put them in places where there aren't any lymph nodes. Yeah. Again, it's emerging evidence and it's showing that it's actually quite good what it's doing. It's all through plastic surgery. In Wales, we only offer LVA on the NHS. If you've got a good surgeon, they may, if you're having a reconstruction, they may do it the same time. But in other places, sadly, it is a private route. Although I do know that the Marsden was doing a study. I don't know where they are with that. Is it good? Yes, I would say it's good. But you need to be the right person to have it. And our right person is they've got to have good lymphatics that we can attach those veins to.
Yeah. Yeah.
The other one then is liposuction. Liposuction dramatically reduces the size of your limbs. If they're fatty, definitely it will make a difference, but you've got to wear your garments. As soon as you stop wearing your garments, that will return because we're not changing functionally how the lymphedema is. We're just basically taking it away and it will come back. So garments then must be worn. But again, you know, quality of life, because your limb looks normal again. Lots of people put up with wearing the garment because their limb is now, you know, a quarter of the size.
The thing to remember about LVA as well is if you've got venous incompetency, so if the veins are already under pressure, so you've got varicose veins or superficial veins, then you don't want to offload the lymphatics into those compromised veins. So that has an impact on not being able to have a really good result with LVA, because what will happen is your veins will cause swelling then as well. You know, it'll flood back into the lymphatics and into the tissue. And then you could end up with a venous staining then, which can be a problem as well. Yeah. But there we are. Yeah.
Okay. Does anybody have anything else? So maybe if we come back next time, we can tell you about some of the innovative things that we're doing in Wales. We've got lots of programs. Cellulitis is a big one, but maybe we'll come back and talk to you about the surgery. And maybe we'll get one of our surgeons to pop on. Although, you know, as he tells me, Melanie, I'm only the man with the knife. So, but, you know, we're the ones that decide who has surgery. We're the ones that follow them up. We're the ones that scan and decide who has it. But Amma is fab. So we'll see if we can get him on. Cannulation, is it a no in the affected arm? If you can go in the opposite side, because it's that risk, you're creating an opening that you may get a cellulitis. But if it's a medical emergency and they can't get blood out of you, don't worry about it. Just let them, you know, have the treatment wherever you're having. So definitely. Pneumatic compression machine, yeah, we're doing a study about that at the moment. We're using the Lymphacyst, that's a Huntley product. What we are doing is we're giving 20 people the Lymphacyst so that they can use themselves at home for 6 weeks. And we're measuring the impact. Does it improve things? So I can tell you more about that next time. But yeah, it mimics massage. What we are finding is if you wear a garment underneath it, apparently that works even better.
Oh, wow. Okay.
So any more, or we'll call it a night, but we're more than happy to come back.
The link's not working, Mel, so I'm just looking to see if I can find it, Google it, and then put it in the chat, because it's not. If you search lymphedema films, Lymphedema Wales Clinical Network, we're all over. We pop up all over the place. It's quite funny the other day. Somebody said we're interviewing tomorrow for the psychologist, which is really exciting because, you know, I've already said that the staff are probably in queue for some treatment as well. But what I would say is we were looking at and one of the psychologists, we felt like we were being interviewed by the psychologist last week, and they were saying, we've Googled you and we've seen this about you, and we were like, oh dear, you know. But that's fine. I'm sure they psychologically assessed us before they agreed to have the interview, so that's fine.
Yeah,
but I'll try and find the link.
What she said was, we've seen you on YouTube. And Melanie, she said, you swore. And then of course I thought, oh my God, what's on YouTube? And then I did look at it, and it was in a wounds conference. And actually we were quite funny, Car, weren't we? But I did swear something, I can't remember what it wasn't major swearing, but you know, it was something like bloody or something. But yeah. So we are on YouTube. It's
just a passion, really. We do get passionate. And you know, we get frustrated when other healthcare professionals don't consider the compression or understand, you know, the patient journey, and you know, we do get kind of fired up a bit in our belly, but there we are. We don't apologize for it anymore, you know. That's
okay.
it.
I've got a new link.
Can I ask a quick question?
Yeah, of course you can. The new link is there. If you go into that, all our videos are there. Try that.
There we are.
Yeah. Yes, ask a question.
I'm a student therapeutic radiographer, and I suppose I was just wondering, as part of the patient pathway, obviously lymphedema is something that is a side effect in a lot of treatment. And again, I suppose it's just knowing how to have that bit more of an in-depth conversation with our patients, because we'll see them maybe like weeks at a time. So we do have a lot of time with the same patient. And I suppose it's just knowing how to give the right signposting, and just in making sure they're well informed.
Okay, so definitely skincare, and you all now know the reasons why we recommend skincare: to prevent a cellulitis, to prevent an infection. So definitely recommend your patients to keep an eye on their skin, make sure that you know, they do use a moisturizer. Exercise, vitally important, because that's moving things around. Signposting, there are numerous charities out there. The Lymphedema Support Network, LSN, great charity. There's some fabulous ones on Facebook. Lymphoedema, really active on Facebook. That's another great one. But if you want to, did we put our email up? I think we did. If you want to email me, then what we can do is we can send you some of our education links. You're more than welcome to, you know, do some of our courses. We do them virtually as well as face-to-face, and you'll get a lot more information what you should or could be telling patients and what you shouldn't be telling patients. I'm very much for evidence. Stop the myths. We've got to stop the myths, because there's, you know, there's no point.
Definitely.
People get really worried about, oh, I haven't done this, I haven't done that. Or when they get lymphedema, or if they get it, then they think, I've done something wrong. I must have done it. I've caused it. You haven't caused it. You're just one of the unfortunate ones. And just because you didn't do your massage one night doesn't mean that that's why you got it. You know, we need to be really saying what the truths are.
Thank you.
Another question, rings on affected fingers. If you want to wear your rings, wear your rings. Make sure that they're just not tight. But wear rings. Yeah, wear them. So you haven't got to not wear them. I know some patients come in to me and they, you know, they've seen other people and they say, you know, I've taken all my wedding rings off, or my engagement rings, because I was told not to wear them. And the first thing I say to them is, get them back on, wear them. If they get a little bit tight, then you know you've got to do your hand exercises. If that doesn't decrease it, then get them made slightly bigger. Wear your rings. I had one patient came in to me, she was a gynae cancer. Her legs were hairier than my husband's. And first thing I then said was, okay, can I just ask you about this hair? What is it something you feel strongly about, that you like your hair? And she said, oh no, I was told I was never allowed to shave my legs. I said, shave your legs. It's not a problem. Shave your legs. And, you know, for her, I'd given her £1 million. She was a young girl. You know, why would we give this information when there's no evidence behind it? It's really sad. Do tamoxifen contribute to lymphedema? There's not much evidence on that. Now, I can't say yes and I can't say no because there's no evidence on it. Maybe we need to look into that. I would probably say no. What I can tell you is your amlodipines, your blood pressure, your first line, they do cause oedema. So if anybody's on like nifedipine, amlodipine, then you may find, and you've got ankle swelling, then you may suggest to your GP, look, this is a side effect. Could I go on to second line blood pressure medication, please? So when you're having chemo, you may find that you get oedema. Once chemo is out of your system, that oedema will go.
There's a question is saying
swelling is a side effect, is it? Of lower limb?
If you look at nearly every medication,
I know.
nearly everyone will say you might get a rash and you might get swelling or you might get this, and they cover every single angle. So they put, you could have this and you could have that, but it is good to be aware of that. And it is anything that changes when you take any type of medication, you should report that back, because it might be a new symptom that other people haven't had, or it might be something that's reacting to another medication. Sorry, my dog is now barking. Another medication that you might be taking. Sometimes it's the combination of the two that is the problem, but you should always report that back. Yeah, definitely.
And definitely, you know, as I said, if you need the tamoxifen, you need the tamoxifen. We'll deal with the edema.
Questionable.
Questionable, I know.
Yeah,
I know.
Very low risk for recurrence. So
I think then that's really important that it goes back to individualized care. And maybe this is where the NHS has gone slightly off, in that we do less individualized and we put all people together. You know, all breast cancer patients are together. Yes, we distinguish them slightly, but actually it should be individualized. We find that with lymphedema, you know, everybody's given this particular garment and we say, why? Why are they all given that garment? They shouldn't be. You know, if somebody is a really fit person, they may do better in another type. And Karen and I feel really strongly about patient-centered care and individualized care. So, yeah. Okay.
Great. We might be finding out questions. I'm not sure. If anyone does have any more questions, Melanie, am I all right to share your email and people can get in touch with you?
Yeah, of course you can. Perfect.
I'll send out an email in the next few days with all the links that we've sent today, that were shared today. And I'm going to upload this recording to our YouTube channel so that you can watch it back or recommend it to anyone that you think would like to see it. And a little feedback form. So if you've got any feedback for us or for Melanie and Karen, then that would be lovely as well. But yeah, thank you both so much for your time as well.
The other thing I was going to add, if you are on Twitter, Karen and I are both on Twitter, and we do put things on about new things that are happening. I'm Lymph at Wales, I think. No, what am I? Lymph Wales, maybe. But I'm sure
I'll find you and share.
Yeah, Lymph Wales, I think it is. But we do say about different programs and, you know, proms and prems. If you ever want any of those, use them, and we're more than happy that they can be used. So I'm free of charge, Lee.
Last Mel ILF conference, that might be of interest to
people. I can't believe I forgot that. Right, International Lymphedema Framework Conference. It's in Nottingham next June, and there is going to be a Patients' Day. It's on the Thursday, I think.
Hang on, I'll tell you now. Let me look.
You'll have to find out what day it is now. It's on the Thursday. There is a full day.
15th of June.
15th of June. It's in Nottingham Conference Centre. I don't think there's going to be a charge. If there is, it's something like £10. And you've got Professor Peter Mortimer, you've got Christiana Gordon, you know, really big names in lymphedema. I think I'm doing a little bit here and there. I'm actually the scientific chair for my sins this year. I know. So I am doing a little bit, but
it would be lovely to meet some of you.
yeah, I'd love that.
As we are here, we are in person, so we'll have a cup of coffee and a chat with you. So it'd be really great to meet some of you.
Yeah. So if you're anybody from Nottingham area, come.
That sounds great.
Anyway, Merry Christmas to one and all. Keep well, everybody.